Now, there are three very important words associated with human placenta. And what are they? The human placenta is discoid in shape. Second, it is hemochorial because of direct contact of the chorion with the maternal blood. That is, in the intervillous space, we know the maternal spiral arteries are there. So here the chorion is in direct contact with the maternal blood. Third is deciduate, and it is because some of the maternal tissue is shed at parturition. Now the decidua has got three layers: superficial compact layer, intermediate spongy layer, and the basal layer. So after delivery, when the level of progesterone decreases, this part of this decidua from the spongiosa layer is shed off along with the placenta, and so it is called deciduate type of placenta. Now few words about its weight. It weighs 500 grams at term. And what is the ratio of the weight of placenta to that of the fetus at term? At term we take the weight of the fetus to be 3 kgs and the weight of placenta is 500 grams. So the ratio is 1:6 at term. Now the next very important question, that at what gestational age the weight of the fetus and that of the placenta are equal, and your answer is 17 weeks of gestation. 17 weeks of gestation, the weight of placenta and the fetus are equal. Now here there are two more terms that I would like to discuss. One is hemodichorial and the other is hemomonochorial. Now in first trimester of pregnancy, the villi has two layers of lining, the outer Syncytiotrophoblast and the inner cytotrophoblastic, and the two layers are all continuous. So this is dichorial, two layers. And as the pregnancy reaches term, this cytotrophoblastic layer becomes discontinuous and sparse. Only scattered cytotrophoblastic cells are present so as to aid in the exchange of nutrients and oxygen. And this time the placenta is called hemomonochorial. Now let us discuss few name structures associated with the placenta. Number one is our Hofbauer cells. Now what are these Hofbauer cells? They are the phagocytic cells which trap the maternal antibodies crossing the placenta, and thus they act as immunosuppressive. And in early pregnancy, they are derived from the villous mesenchymal cells, whereas towards the late pregnancy, they originate from the fetal hematopoietic stem cells. Now there is one important thing about these Hofbauer cells. The Zika virus, it affects these Hofbauer cells, and it is through this that they infect the fetus. And what is the most important feature of Zika virus infection? It is microcephaly in the fetus. Now our next named cells are PEG cells. These cells, they are present in the fallopian tubes, and this is also a very often asked question. They are present in the fallopian tubes and their function is not known. The next cells that we have are Langhans cells, and as we discussed earlier, the cytotrophoblastic cells, they are also called Langhans cell layer. The next name structure that we are going to discuss is Nitabuchs layer. What is this Nitabuchs layer? It is a layer of fibrinoid degeneration of the Syncytiotrophoblast present at the junction of the cytotrophoblastic shell and the maternal decidua. Now this Nitabuchs layer, it limits the further invasion of the trophoblast into the decidua, and if this Nitabuchs layer is absent, then it leads to placenta accreta. Now we will talk about the development of the placenta. The placenta is formed by two sources, as we have already discussed. There is one maternal side of the placenta and fetal side of the placenta. The fetal side of the placenta is formed by the chorion frondosum. And what are these chorion frondosum? They are the proliferation of the villi present on the side of the decidua basalis. So this chorion frondosum will form the fetal side of the placenta, and the decidua basalis forms the maternal side of the placenta. As you can see in this diagram, this is our villi, this is the intervillous space. It is here that the maternal arteries come and open, and this is the villi which is lined by the outer Syncytiotrophoblast, which is a multinucleate cell layer, and the inner cytotrophoblast, which is a single cell layer. Now, this chorion frondosum, it has got many finger-like projections called villi, and in between the villi there are intervillous spaces. The Syncytiotrophoblast and the cytotrophoblast, they grow inside the villi, and now this villi have a trophoblastic shell, and this structure, this primary structure is called a primary villi, which is formed between 11 to 13 days after fertilization. Now, after this, the next thing to happen in sequence of events is the maternal vessels opening in the intervillous space, and that occurs at 15 days after fertilization. So, if you are asked when is the uteroplacental circulation established, that is at 15 days of gestation, when the maternal spiral arteries, they open into the intervillous space. Now, we understand this again by the diagram. This is our fetus, this is the uterine cavity, and we have the chorion frondosum with the multiple finger-like projections called villi, and this is our Decidua basalis, Decidua parietalis, and this is our Decidua capsularis. And this is the picture for our primary villi, in which the Syncytiotrophoblast and the cytotrophoblast, they grow inside the villi, and this occurs at 11 to 13 days of gestation. Now, between the 13th and the 16th day, the extra embryonic mesoderm grows inside this villi, and this villi now become the secondary villi. So, secondary villi is formed between 12 to 16 days after fertilization, and we can see here this is the extra embryonic mesoderm which is growing inside the villi, and this is the structure of a secondary villi. Now, the next thing to happen to establish fetoplacental circulation is the opening of the fetal capillaries into the villi, and which makes the villi a tertiary villi. So, this is a very often asked question, when is the fetal circulation established? Earlier it was said that it is formed between 17 to 21 days after fertilization, but the recent studies, they say that the fetoplacental circulation is established by 17 days after fertilization. And as we can see in this diagram, there are the fetal blood capillaries opening inside this mesoderm, and this makes it a tertiary villi. Now, the next thing that we are going to talk of is the placental barrier. And what is this? The layer separating the maternal blood from the fetal blood is called placental barrier. Now, what are the layers of this placental barrier from outside to inside? They are the outer Syncytiotrophoblast, next to it we have the cytotrophoblastic cell layer, then the extra embryonic mesoderm, and then the endothelial lining of the fetal blood vessel. This is the layer which separates the maternal blood present here from the fetal blood. We have not included the endothelial layer of the maternal blood vessel. It is so because the endothelial layer of the maternal blood vessel has been replaced by the cytotrophoblast, and this is called Trophoblastic invasion, about which we will be learning the next. Now, what is the thickness of this placental barrier? It is 0.025 mm, a very thin membrane. Now, let's come to the trophoblastic invasion. What is this? This maternal spiral arterioles, they open into the intervillous space on 15th day after fertilization. Now, the lining of these spiral arterioles, they are replaced by the cytotrophoblast, and the musculoelastic media, it is destroyed and replaced by the fibrinoid material, that is the degeneration of the Syncytiotrophoblast. And this trophoblastic invasion, it occurs in two phases. First, in the 10 to 12 weeks of gestation, in which the invasion is up to the decidual segments of the maternal arteriole, and the second phase, which occurs in 16 to 18 weeks, when it occurs up to the myometrial segments of the arterioles. So, in this trophoblastic invasion, as we have discussed, that their lining is replaced by the cytotrophoblast and the fibrinoid material. So, the arterioles become distended and they are converted from high pressure vessels into low pressure vessels, so that more volume of blood goes to the fetus. Now, if this trophoblastic invasion is absent or is incomplete, then the resistance in the maternal vessels, that will remain high, and the blood supply to the fetus will remain low. and this is called Uteroplacental Insufficiency, and this overall condition results into PIH, that is pregnancy induced hypertension in the mother, IUGR in the fetus, and the placenta becomes placenta accreta as it invades deep and deep into the myometrium so as to meet the nutritional requirements.